Hello, everyone. Welcome to today's webinar. Today, I'm Amanda Giacomazzo, and I'll be the moderator for today's webinar. Today, we'll be hearing from 5 speakers about their experiences in participating in the National Teleconference Network for Supervised Consumption and Overdose Prevention Sites. We'll also hear about lessons learned and key themes that have come out of that teleconference network. So before we begin, we would like to acknowledge that today's presenters and participants who are joining are based across the country on traditional lands. The CATIE office is based in Toronto, which is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, and the Mississaugas of the New Credit. We would like to acknowledge these traditional territories and the traditional lands across the country, as well as the original people who lived on them. So with that, we'll jump into today's agenda. So today's webinar is an hour and a half long. It'll start with Patrick McDougall, who will provide an overview of the National Teleconference Network for SCSs and OPSs. And then we'll hear reflections from 4 speakers, so Sean, Lorraine, Jason, and Cecile. And I'll give a bit of an intro to each of those speakers prior to their presentations. We'll then have approximately 30 minutes at the end of the teleconference to do some questions and answers. So if you have questions throughout each of the speakers' presentations, please feel free to ask those in the question box, which is in the panel on the side of your screen, and then we will get to those at the end of the webinar. So with that, I will pass it over to our first presenter. So Patrick McDougall is the Director of Knowledge Translation and Evaluation at Vancouver's Dr. Peter Center. Patrick facilitates the National Supervised Consumption Overdose Prevention Site Service Providers Teleconference and was recently elected as the co-chair of the Pacific AIDS Network. He has a master's degree in public administration from Dalhousie and a Bachelor of Arts from McGill University. So Patrick, I will now pass it over to you.
Okay, well, thank you, Amanda. I'm going to try sharing my screen. Okay, so as Amanda said, my name is Patrick and I work at the Dr. Peter Center, and I'm going to share my perspective from facilitating a national, the national conference, teleconference. I wanted to begin by acknowledging that the land on which the Dr. Peter Center resides is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and the Tsleil-Waututh nations. So in terms of what I'm going to talk about today, I'm going to talk for about 12 minutes about the teleconference, how it started, the growth in the number of people participating. Then I'm going to go over a summary of key themes that emerged over the last 2 years. And Amanda has kindly shared a key themes document on the through the webinar, and we can highlight that a little bit later. So this is a photo of the room at the Dr. Peter Center where we do supervised consumption services in our day health program. And service users at the Dr. Peter Center have renamed this room the Harm Reduction Room. This photo shows the room after we did a peer-led redesign last year, but we actually started offering supervised consumption services in 2002, and it's very much one service among many others for registered clients here at the Dr. Peter Center. And for folks less familiar with the history of supervised consumption services in Canada, it was basically Vandu, Dr. Peter, and Insight that were publicly known to provide this service up until 2016 when it expanded more broadly. In the same year, in 2016, we applied to the Public Health Agency of Canada's Community Action Fund stream for a project where we would do capacity building for agencies that were starting up supervised consumption services across Canada. When we wrote the project proposal in early 2016, we were focused on providing more of a deep dive support for a smaller number of agencies. And we did this in part because we thought there'd be more of a gradual uptake of supervised consumption services across the country at the time. So our PHAC project sought to provide capacity building for 12 agencies starting SCS over 5 years. The plan was to work with 4 agencies in the first year and then 2 more agencies each subsequent year. In retrospect, even in early 2016, we should have seen the opioid crisis was already showing clear signs. So in retrospect, we should have seen that there would have been that there was going to be a much faster uptake of supervised consumption sites across Canada. And to give a sense of numbers around that faster uptake, in early 2016, there were 2 supervised consumption sites with a federal exemption. And today there are over 40 supervised consumption sites with that federal exemption. And in addition to those, there are probably another 40 or more overdose prevention sites across the country. The first 3 agencies we started working with for this project were the Works, Parkdale Queen West, and South Riverdale in Toronto. And there were several components to the larger capacity building project. What we didn't have built into the project was a space where agencies could talk with other agencies that had recently started the service or were about to start the service. And it was Sean who had this idea to do this. So in 2017, September 2017, we hosted the first teleconference with SCS service providers in Vancouver, Surrey, Montreal, and Toronto. In the first call, we just talked about what was top of mind in terms of service providers who had just started the service and what was top of mind for folks who were just about to start the service. I think we felt that it was a good call, so we decided to have a second one and invite a few more folks. And we basically kept growing through a kind of snowball recruitment where people on the call would suggest inviting other people and agencies, and the calls have pretty much continued on since. This graph gives a sense of the growth in the number of teleconference participants. I should say that these numbers are the number of people on our email distribution list. The numbers don't represent how many people have actually attended each call. I'd say in the first 12 months, we generally had 15 to 20 people on each call. After that, it would have gone to about 25 to 40 for each call. But again, you get a sense of just the growth and the interest in people wanting to participate in some fashion. This graphic gives a sense of the journey of the teleconferences. The first few teleconferences explored numerous topics related to service delivery in a broad manner. And because we were a small group, we could each do an update and then circle back and have a group discussion about the things that came up during the updates. Then in 2018, we started focusing on specific topics. For example, in January 2018, we talked specifically about peer assistance, also known as peer-assisted injection. There were a few agencies interested in starting this at their SCS, and then OPS had developed some detailed policies and procedures about peer assistance and shared this with the group. And I don't know all the details about how this came about, but 5 months later, Health Canada announced a peer assistant pilot project with a few agencies. Another frequent topic of conversation was the community engagement piece, with sites sharing strategies and practices that they had developed. At the end of 2018 and beginning of 2019, we started having more presentations and panel discussions. We had one on IOT, or intravenous opioid agonist therapy, and several related to overdose prevention strategies within housing, which is of course where the majority of the overdose deaths in BC have occurred. We also had a panel discussion from agencies that have been participating in the peer assistance Health Canada pilot project, which was really great to be able to hear these service provider accounts of the practice so quickly after they had started. As we got to mid-2019, or this year, we changed the format to a Zoom video call, which had a few features that made it a little bit easier for facilitation and presenters. And also in 2019, we developed a list of key themes from the teleconference going back to the beginning. So as mentioned, you can access this document, I think, on the right-hand side through the handouts. It's called Key Themes, SCS, OPS Service Providers Teleconference. You can see the full document there. There's essentially 5 key themes that the teleconference discussions have centered on: expanding models, operational considerations, navigating regulatory considerations, community engagement, and supporting staff resiliency. I'm going to talk about each theme just in a really top-line summary way. So over the course of the calls, we heard a lot of interest related to expanding service models to include some of the following, and I won't mention everything, but incorporating SCS, OPS, and housing settings, assisted injection, whether it's peer or staff assisted, inhalation services, women-only or trans-only locations or hours, allowances for splitting and sharing of drugs, and access to low barrier safe supply. And certainly there was a lot of talk about decriminalization as well. A second theme that captured a lot of discussion over the teleconference was operational considerations. And I've listed a top-line summary here as well. They include strategies to prevent wait times for people wanting to access the service. Discussions around people using outside facilities or in the washrooms, and complex overdoses. Navigating regulatory considerations has been another frequent theme of conversation on the teleconferences. The status of both SCS and OPS have been dependent on political climates and in some cases vulnerable to political changes. And the steps involved in the application for these services can be time and resource intensive. Restrictive regulations can sometimes be at odds with the goal of providing low barrier access to care. And some examples that service providers highlighted were around, again, assisted injection, splitting or sharing of drugs, and hiring of staff with a criminal record. Engaging other partners outside of a group of service providers has been really important here, and Cecile is going to talk a little bit more when she speaks. A lot of discussion on the teleconferences has focused on community engagement. There's been a number of organizations that have faced different levels of community pushback, including negative media, court challenges, and needing to relocate services. And over the course of the last 2 years, service providers have shared and discussed strategies, including engaging stakeholders in the media, hosting tours, and engaging community consultations. Supporting staff resiliency, service providers on the teleconference described trauma and burnout resulting from the overdose deaths of people that staff have worked with for years. Or responding to overdoses outside of the SCS and OPS. We've talked a lot on the calls about specific strategies related to supporting well-being, including dedicated debriefing time, also capacity building opportunities such as peer employee networks. Staff fears around job security has also come up in jurisdictions where there's an uncertain future about SCS or OPS. I should always feel like I should say with this slide that staff, I mean, we all know that the people most affected by the overdose crisis are those people who use drugs. And I think staff resiliency is probably often the last point to come up for a lot of staff. This may seem a little bit of a dull slide, but I think it's good to reference that in between teleconferences, there is a lot of sharing of resources that goes on, as you can see by this list. And I wanted to finish today my section by talking quickly about what I think has worked well on the teleconferences and what I think could be improved. And I'll just highlight a few. So in terms of working well, we're really fortunate that we have an excellent interpreter, Sophie Wertheimer, who has made the teleconferences so much more bilingual. I regularly hear that service providers really enjoy hearing what's going on across the country. And that while we have some new partners who have joined the teleconference, I think the large majority has stayed service providers, which I think is really important. In terms of what could be improved, the updates we do are probably too short now to be able to get into a lot of detail. So I think we do need to start moving towards smaller groups. With the national teleconference, we try and do it at a time that can work within everyone's workday across different time zones. But we know with a number of SCS and OPS, the workday can be around the clock, and some folks can't join because of different work hours. And finding out why folks have stopped joining the calls would be a good idea, especially if a smaller group might re-engage the person. So thank you. I'd like to thank and acknowledge the contribution of everyone who has participated in the teleconference. And I want to thank our funder, PHAC. And with that, I'll pass it over to Sean.
Thanks, Patrick. I'm just going to introduce Sean before I pass over the controls to her. So Sean Hopkins has been the manager of the Works Harm Reduction Program at Toronto Public Health for 28 years. During her time at the Works, she implemented the first public health operated opioid substitution program in Canada, the first Canadian public health run naloxone program, and the first public health operated supervised injection service in Ontario. Since 2017, she has operated the supervised injection service in the heart of downtown Toronto. So with that, I will pass it over to Sean.
Hi, everyone. Just waiting for my slides to come up.
We can see them.
Okay, I can't see them.
Uh-oh, okay.
Okay, just give me a minute here. Just gonna move something over. Okay, sorry, everyone. While I'm just readjusting my screen, I just want to say thank you to the Dr. Peter Center for organizing these sessions. They've been just so helpful. I think I speak on behalf of everyone who's participated. It's been a great experience, and I think we have a lot of expertise across Canada on this issue, and this opportunity to share information has provided us all with a rich way of learning. I think we're all the experts now, surprisingly, so it's been just great. So I'm going to talk a bit about my experience with the teleconferences. The next slide, I'm sorry, I don't do this very often. Somebody could just let me, oh, here we go. Okay. So just to talk a bit about, Patrick mentioned that the idea was mine, but I think it was a group of us who were saying it would be wonderful to have the opportunity just to get together. Obviously, distance in Canada is a barrier, so the teleconference was just, you know, an ideal opportunity. And so I think a lot of us were saying, wouldn't it be great to get together, talk about what we're doing, learn from each other. So, you know, the need really came from the fact that we were all pretty new, except for Vancouver, operating this service. And there's such importance to learning from the people who had been doing the work. You know, as I said, being experts in Canada, internationally, people probably had been facing the questions or had faced the questions that we all had in our day-to-day work. There's also such value, I think, you know, in Toronto, we're pretty lucky here. We have a group of about 9 organizations that get together fairly regularly to talk about our experiences and how we're doing the work and what we've learned. So giving that opportunity and sharing that opportunity across Canada was also really important. Supporting each other, it's very stressful work, as we all know, and just to have somebody express that, you know, they face the same thing that I faced yesterday was, I think, helpful, just to be able to say, yeah, that's really hard. This is how we dealt with it. Sharing strategies, resources, supply ideas, you know, things like what kind of tables we use, the crash cart, what's on it, protocols, job descriptions. And, you know, one of the really important parts of all of this is how we support staff, people with lived experience who work in the services and do the work every day. So as Patrick said, we did talk a lot about that. Just hearing each other across the miles, relating to each other, I found was really important and valuable. So I think that was really a summary for me of why there was a need for the teleconferences. So what was achieved? You know, I think there's a lot more that was achieved than what I'm saying here, but you know, a sense of community. We're all working together, we're doing this work. We can reach out, not just on the calls, but we made a lot of connections. Here we had people from across Canada coming to visit, and people who we had met on the teleconference. And so I really do feel like we have a sense of community on this issue across Canada. An increase in the knowledge base as well, so resources that we didn't know about, if there was an evaluation that's been done, what were the results, just knowing that those things are happening has been helpful. Here in Toronto, we just started with a drug checking project, so we've been sharing that information, those lessons with the group. The opportunity to brainstorm difficult issues like how to work in the community, what things work with stakeholders, local stakeholders. How do you introduce and then maintain good relationships with your community members? So just sharing what works and what doesn't. It's not always the same across Canada. There are differences. So why didn't something work? What could maybe be tweaked to make it work in another community? What did we learn from each other around community engagement? So here for us at the Works, I think this has been, it's been a challenge. I think we in Toronto embarked on a process to introduce these services using a lot of community engagement, sharing key messages and helping to kind of work it forward. And then after implementation, we had to learn what was working and what wasn't. So I think the strategies that we've all developed are quite similar, you know, in terms of developing a community liaison committee, keeping the communication open, being very personal in the neighborhood, keeping the outside of your service fairly clean and tidy. And we found that all of the strategies can work. We just have to have the time and the funding to be able to do them and keep doing them. Also recognizing that sometimes it's not going to be easy, that there will be concerns in the neighborhood that are very difficult to address. But you know, as I said, we just have to keep going. So outreach, constant communication with the neighborhood, being honest about the service, having good data about who's coming in, what kind of service volumes, any kind of citywide data that you have about paramedic services, the fact that this opioid overdose epidemic continues. So we definitely need more of the services, having consistent talking points, involving people with lived experience in your approach and your service, and having joint community projects if you can. I think working together with, alongside you know, in our example here, Ryerson University, right next door, being on committees there, having them come over for tours, all of those things have, I think, had a positive impact on our road here. Going forward, you know, I was asked to speak to whether or not there's a need for continued teleconferences, and I really do strongly agree that we need to keep having the conversation. New people are coming on or trying to get funding and approval to implement services in their neighborhoods, and so making those connections is I think going to be an ongoingly important thing to do. The other thing that we've been doing, having subgroups taking on specific topics, like working with stakeholders. We had a session as well about washroom safety, doing more specific and maybe targeting people who are just getting started, having a group so that they can get together. Maybe they have different issues, and those that are more evolved or taking on different parts of the work. So I think it's important to kind of have those subgroups as well, so that the information being shared and discussed is relevant to the people coming together. That is the end of my slides. I will be taking questions once the presenters have finished. And I want to say thank you to everyone who's on the call for listening and being interested. And again, thank you to the Dr. Peters Center and to Patrick in particular. He's been very committed to bringing people together. Just an overall great guy to work with. So thank you, Patrick.
Thanks very much, Sean. So I will introduce Lorraine. Lorraine Barnaby is currently the Urban Health Manager, Supervised Consumption Services at Parkdale Queen West Community Health Center, and has worked in the field of harm reduction, homelessness, and health promotion for over 20 years. For almost 20 years, she has overseen the development of numerous harm reduction, health promotion, community-based, and community development, engagement, and advocacy initiatives. She brings extensive experience in working with governmental and not-for-profit organizations, committees, and task groups. So Lorraine, I will turn it over to you.
Peters Center, they've been really invaluable. Even before we were opening, they were of great assistance and really have created a community across Canada for people working in supervised consumption and overdose prevention services. So I want to talk a little bit about the impact of participating in the teleconferences has been. As Sean said, it's been an amazing opportunity to share and discuss service models and operation needs and challenges. You know, when we first opened up our SIS, there weren't that many of us across Canada, but I knew that one day there would be just so many, and it would create this amazing community and would raise all our voices around being able to advocate for change and to refine our service delivery models. It's really been important in terms of facilitating the services in the operational stage to provide support to each other. So those of us who are opening up these new services, really, it was great to be able to tap into the Dr. Peters Center. They provide a lot of consultation services, but the teleconferences allowed us to really kind of share information, to raise challenges, and to really talk about what we were doing and what the challenges were, and to share some of the tools and approaches. But so it was really important in the planning stages. But it's also allowed us to then provide support to folks who are now in the planning stages. So for some of us who opened up services, we later then could provide some mentoring support to folks who were starting the planning. So in a sense, it created a succession strategy where those of us who got in the beginning were able then to give back, and then everyone's just sharing, and it's like a nice incubator, as well as sharing tips and documents. All been very important. And as Sean talked about, you know, drug checking services. that some of us have those. We have it at our site, but others do not. But we're all kind of tapped into what's happening in the local scene and what's happening provincially. And by sharing that information, sometimes we're able to kind of connect with a drug supply and how people might be presenting or the type of overdoses we're seeing or medical emergencies. Or we can see, oh, that's happening over in that province. It's probably going to start to happen in my province. Let's start to do a little bit of planning now. So that's been very valuable. And as you all, many of us experienced over the last year, we've had changes in our government. Some provinces and cities and communities have had their services under attack or have had funding pulled. So it's created opportunities for us to strategically prepare for some of the present and future provincial and political and federal developments that might impact our services. An example would be, Ontario saw some of these changes and some of these impacts, and we're able to kind of come together and have discussions, but we're also able to use Dr. Peters Center as a hub to bring folks across Canada for other meetings, specifically just to focus on what we're experiencing, some of the strategies, and to collectively make decisions around how we want to deal with this as a national issue. And of course, there's been lots of operational considerations, from the design to the furniture to equipment. It's such a specialized service, and if you haven't done it before, there's a lot of having to reinvent the wheel. So having a national community allows us to actually share and ask questions and go, oh, that was a great thing, and let me tell you where I bought it from. Or, this is something you might want to consider in the design of your space. Ventilations came up quite a bit for some of us. For our site, we actually had 2 Ministry of Labor inspections, and we were able to kind of reach out to the community to get some information around whether that had shown up in another province, or to tap into researchers who were looking at ventilation and health and safety concerns. And it really helped us prepare for our second Ministry of Labor inspection. And another way in which being able to talk about ventilation was important was when people were looking at offering inhalation services to see what some of the challenges Lethbridge had encountered and what some of the design elements, and so that can be then fit back into our more local and site-specific discussions. And of course, there's always some challenges around, are you a standalone or are you an integrated service? And what are some of the strategies used to integrating a service in a community health center? So there's been an opportunity for some CHCs to share some strategies. And of course, there's always a lot of data requirement with the service, whether it's through the provincial government or through the federal government. And there are challenges when you're running an anonymous confidential service, and yet you're required to kind of maintain all this data collection. So being able to talk about those challenges, especially in regards to nursing and charting and documenting nursing care, it's been helpful to be able to identify those challenges, to have a little bit of brainstorm opportunity, and where possible to actually share some of the tools that people have found useful around that. Assisted injection, the Health Canada made it a pilot project. There was lots of opportunities to talk nationally around some strategies around how to bring more agencies into what was a really small pilot project. Only 6 agencies across Canada were originally chosen. So it gave another opportunity to do some strategy, but also once we were ready to roll out those services, to hear a little bit about some of the challenges people were experiencing, but some of the strategies that were working, and then you could test them out in your own site or share some of the things that you've learned. And of course, there was the documentation challenge as well. And some of us are looking at IOTS or different types of OATS programs. So again, as we start to look at how do we improve services, how do we meet the needs of folks coming into the services, these conversations become so important. Oops, I'm not finding my page going down. Thank you. I won't talk too much about some of this because some of it's been discussed, but staffing models and training needs, the type of training we'll do before we opened up and the training that we do now that we're running is very different, and there's some unique challenges to that. But even looking at, you create a staffing model and then you hear about another staffing model, and you can start to share job descriptions and job postings and what were the challenges and the merits of those different staffing models, and it helps you kind of re-examine, reflect on your own model and to make strategic changes. One of the big issues that have come up for our agency and some other agencies is the issue of staff using a service. And so it created this really safe environment to have open conversations and to actually share policies, which always helps agencies kind of move the needle around their own practices, because it is a complicated situation. There's ethical issues, there's policy issues, confidentiality issues. The challenge of creating a welcome space while also managing service client flow and making sure that it's a safe space for staff and clients is always something that's ripe for discussion. And so being able to hear what other sites are experiencing is really important, because some of us are sometimes working in somewhat isolation depending on where you are nationally. This might be your only opportunity to actually have a conversation with colleagues who truly understand the unique needs and challenges that these types of services present themselves. And it's also part of that mentoring. Whether you've been open for 2 years, you've been open for 2 months, or you're just about to open, these discussions become really rich and important environments. And looking at how do you build trust with service users. And again, this was around the housing sector. Some sectors have unique challenges, so creating opportunities for them to have discussions became really important. And I need my page to go down, it's not going down again. I'm wondering if someone can, oh, here we go, thank you. Going forward, so there's some of the ideas were around, we have this now wealth of information and knowledge amongst all of us who are managing and working in these services. So it would be great for Dr. Peters Center to establish a national repository or a resource library, a hub that would encompass policies and protocols and best practices and design and floor plans and furniture equipment. So you could always go to this and go, oh, I need this policy, or I'm about to open up and I'm looking at what kind of equipment I might need to purchase and looking at what people are recommending. I think it's something that we desperately need now, because some of us will be leaving the sector at different times for different reasons, and some of this knowledge leaves with us. So wanted to create an archive and a bit of a legacy. And I think in terms of calls, it's important to categorize calls and inform participants of what the content's going to be covered in advance. Because it allows people to kind of go, yeah, this is a teleconference I really need to be at, or I'm going to send this staff person because it's really valuable to them. So many of us have so many meetings, and it's hard to be at all of them. And so knowing what's going to be on the agenda ahead of time helps us prioritize where we should be and who should be there. And incorporating a peer panel via a teleconference. So we have a lot of people with lived experience. So how do we, sorry, I've lost how do we get those folks there? And then lastly, by categorizing calls and informing participants of the contents, again, it helps us be more responsive and it's useful to the audience. So we may want to look at dividing the teleconference around organizational level. Some of us are working for the government, if you're public health, some of us are non-governmental like a CHC, looking at what the role is. Is this a teleconference that a manager or supervisor should be at, or frontline staff? Is this something that's a national of importance, or really about a local situation? And again, presentations and topics relevant to stage of organizational development. So if you're in the planning stage, there may be a teleconference that's much more vital to you than someone who's at an operational stage. And again, is this a healthcare focus, or is this a human resource focus? So I think organizing the teleconferences in advance will help really for those of us on the teleconference to prioritize our time, make sure the right people are at the right place, and focusing the topics so that they're always really relevant. So those are the things I want to share with folks today. And really just say it's been a wonderful experience. And I can't imagine what the last 2 years would have been like without Dr. Peters Center creating all these opportunities for conversation. Thank you.
Thank you, Lorraine. Okay, so our next speaker is Jason Mercredi. He's the Executive Director of AIDS Saskatoon. He successfully advocated for the deregulation of naloxone in Saskatchewan, drug pipes being available in Saskatchewan's needle exchanges, and co-founded Canada's National HIV Testing Day. He also designed and implemented Canada's first Indigenous language condom campaign and is currently establishing Saskatchewan's first safe consumption site. He is of Dene, Métis, and Scottish ancestry and was born and raised in Treaty 6 territory and the homeland of the Métis.
Great. Thanks for having me. Sorry I don't have slides. We were literally moving into our new building the last month, and we just opened on Monday, so it's been a pretty busy time for us here. So the benefit for us partaking on the calls has been invaluable. I don't think we would have been able, I know we wouldn't have been able to get the safe consumption site up and running, or even our exemption application in, if it wasn't for the Dr. Peter Center and Patrick and his team. It's opened a lot of doors for us, especially early on when we were looking at how do we do a community consultation, and gathering up the information and then making the connections was a big factor. Us becoming connected with the different services, whether it was at Edmonton or Arches or any of the Vancouver or Ontario sites, it was that we couldn't have done it without it, because that allowed us to, we had a limited amount of money to hire a policy and community consultant, policy developer and a community consultant, and so we really needed to maximize their time, and the fact that we could get those all together really quickly made a big difference. And so we were able to, we had only had them for a set number of months, but as a result, we could plug them in. And the fact that we even mentioned that we were on the calls allowed us to actually leverage that for funding to get those positions in place. So our funders they weren't interested if we were doing it on our own, but the fact that we said we were part of a national teleconference where we were getting advice and advocacy advice, they were more than happy to fund us at that point. And so we wouldn't have been able to get off the ground. As a result of not having to do that gathering of data, which goes back to what Lorraine was saying about there should be like a database for policy manuals and floor plans and all those types of things. It actually freed up quite a bit of our time so that I could really, really hone in on the media and really make sure that our messaging was very, very tight. And that it was very strategic on when we release things, timing, not just for press releases, but also for when we would do maybe a fluff piece on the story, and another time where we go and talk radio. And so myself having that availability, I also early on the calls, I was really paying attention to what other sites were doing for service delivery, and then the strengths and limitations on everybody's different models. And then when questions would come up, because they would always come up with media here in Saskatoon, I've heard this or I've heard that, I've heard bad things, I've heard good things, that we could say why those things were happening, and a lot of times it was, as we know, it's perceived around these types of sites, the perceived issues, and some of them were real, but there was a reason for that. And so being able to articulate that to media really took down the temperature in Saskatchewan, which is very important because we are, we're Saskatchewan, and so conservative province and all that type of thing. And so for us, just the amount of time that it got to, it freed us up so that we could really hone in on our media strategy and then dive deep on that. And I think we've been fairly successful. We just opened today, and we had the conservative radio, talk radio, is giving us very, very favorable stories, very favorable airtime about what we do. And that's because we were able to actually take the time and develop relationships there. And we wouldn't have been able to do that if we didn't have our hands free from having Dr. Peter Center make those connections early on with us and other service providers. As a result, we also got to, when we were developing our policy, because we had a number of policy manuals available to us, we didn't have to reinvent the wheel, which is a big thing when you're talking about organizations. I think most of our sizes are, and I think most orgs are limited administration-wise, and so being able to cherry pick policy and really have discussions either with Patrick or on the teleconferences, or even just with our staff about why we thought certain policies were better than the others or work for our space, really allowed us to design a service delivery model that worked for our area, that we're like not just for Saskatchewan, but specifically for the neighborhood we're going to be in. I think everybody does things really well where they're at, and being able to see the logic behind that, and then pick different similarities. So, Arches was probably the biggest benefit for us because they, they're dealing with stimulants. They have the smoking room, and so they have policies in place that we could say, and yeah, that looks really tight to us. We don't have to overthink this too much. Let's plug it in and then see how it fits in overall. And even things like when people code out, or different code systems that we could implement in the space, all those types of things for emergency, whether it's overdose or violent behavior, all those types of things. Having that availability of those policy manuals was invaluable to us. Then on top of that, it allowed us to then work better with police, which is a big factor in what we're trying to do here with police and fire and emergency services. Is they had questions about our coding policy, and we can say we're working on it. This is what we're doing, and so we develop policy on how police interact with the safe consumption site in conjunction with the police, and they develop policy on how they're going to interact with us, not just the other way. And so we actually, they're our biggest champions right now in the community, which I think if you would have asked me even at the start of this process, a year or 2 years ago, I would have probably said I wouldn't believe you, but because they really see that we're doing our homework, and we were able to take them out with us when we went out to Vancouver. We brought fire and police, and them being able to see the Dr. Peters Center, the OPS, the Mother Center, Insight, like just all the different places in Vancouver really opened up their eyes, and being able to talk to Vancouver Police Department, Vancouver Fire was big for our emergency responders, because now they're our biggest champions in the community, and they really see that these can provide a benefit, which a lot of times they have an adversarial approach, but they've really taken the lead on championing this in the community, and it's because of the good work that Patrick and his team did when we were in Vancouver, and also just letting, like, not sugarcoating stuff when information was relevant. They just tell them exactly what they needed to hear, not what they wanted to hear, and I think that was refreshing for them. And so for us, it was really, really, I can't stress how beneficial this has been. And, because Saskatchewan, we're trying to get our policies up to snuff with the rest of the country. And, our HIV rates are really well known. Our crystal meth epidemic is really well known. Saskatchewan would still be stuck in the dark ages if it wasn't for these teleconferences. And now when we're going around the province, I go around the province fairly regularly. We're hearing a lot of people that say we want to put one in our community. So we have about 6 communities that are knocking on our door that were wanting us to mentor them, and we're just trying to make sure that their ducks are in a row before we bring them, try to connect them with Patrick and his team. But like the spiral effect and the offshoots are incalculable at this point. I think in 5 years this province is going to look very different, and we're very excited for that. So some things I think we could do to improve on I think having a resource library would be really important. I think you got to protect that a bit and make sure it's not available to everybody, but I don't know why we couldn't make it available to researchers or to other organizations that want to start a site, because then they can just get a quick package and knowing who to talk to, because I'm sure we all get inundated with phone calls and text messages and emails, and sometimes you don't know if they're real or not, and just having that kind of screening process to say, yeah, this org's legit or this person's legit, then we know we're not wasting our time, because I think all of our times are invaluable, and I think that would probably be very beneficial. On top of that, I think it was invaluable for us to have police come with us, and I think I would be encouraging any organization that's looking at this, even if your police force is completely against you, opening the site, making them a part of it, and having them come out as part of your tour in Vancouver, so they can see what's actually happening on the street. And because a lot of times I think communities don't realize the extent of the opioid epidemic, or the people in these positions of authority don't realize the extent of it, but when they're in plain clothes, walking around, hanging out, talking to people who use drugs, like we had a police officer in Vandu, we had a police officer come with us to the West Coast Harm Reduction Network, and like they were shocked at what they were hearing and how serious it was. And so we know that that's coming to Saskatchewan. It's not saying that we haven't had overdose deaths. We know we're having them weekly at this point, or every couple of weeks. But we know that it's coming on a big onslaught, and police needed to see that in order to realize that they got to start prepping for that. Otherwise, they're going to be in a bad spot. So I think having police and fire, if available, be a part of the process going forward, that would be probably our biggest recommendation. So thank you.
Thanks, Jason, and congrats on getting your site open. Did you say it opened today?
It opened Monday, but we didn't open the consumption site services. We're still negotiating with the health authority on budget, but it's looking like it's going to be a go for the new year.
Awesome. Thank you.
Yeah. Thank you.
Okay. So our next presenter is Cecile Kazatschinkine. I'm sorry if I said that incorrectly. who joined the Canadian HIV/AIDS legal network as a policy analyst in 2009 and works on issues related to the criminalization of HIV non-disclosure, drug policy, and privacy. She recently co-authored a report on legal and policy barriers to supervised consumption services in Canada. The report's called Overdue for a Change, Scaling Up Supervised Consumption Services in Canada. Cecile holds an honors Bachelor of Arts degree in private law and a master's degree in English law. And Cecile, I'll turn it over to you. Cecile, looks like you're still muted. Still muted, Cecile. Unfortunately,
Yeah,
oh, there you go. Okay.
Sorry, I think I was yeah. So I found a way. Sorry about this, and thank you so much for having me on the call today for this webinar. So for those who don't know the HIV Legal Network, we are not supervised consumption services providers. We are a human rights organization. We defend and promote the rights of people living with HIV and those who are affected by HIV in Canada and internationally. Drug policy and the promotion of the rights of people who use drugs have been at the heart of our advocacy since the beginning of the organization. We advocate for drug policy reform, both in Canada and internationally, and we work to increase access to harm reduction, including in prison. One of our priority, and that's why we are on the teleconference and speaking today, has been and continue to be to support collective efforts to promote and defend access to supervised consumption services in Canada. We do this through research, analysis, advocacy, and community mobilization. Indeed, like in many other settings around the world, and although we've made some remarkable progresses in Canada in the past 3 years, supervised consumption services remain subject to exceptional regimes, legal and policy regimes, due to the criminalization of drug use. And that makes them highly vulnerable to the political context. And although the situation varies from one locality to another, civil society has continuously been obliged to deploy immense efforts for new SCS to open or just to maintain existing services, despite evidence of their benefits and critical need across the country. So this is why it's important to work on removing legal and policy barriers to access SCS, and that's what the legal network is focusing on and supporting local advocates and service providers who are doing the work. If you can change slide, thank you. Just for those who are on the webinar and may not be completely familiar with the legal framework of supervised consumption services in Canada, just a quick recap that because the possession of illicit drugs is prohibited in Canada, staff and clients of supervised consumption services need a specific exemption from the Canadian drug law to operate without risk of criminal prosecution. So basically, if a site before operating doesn't get an exemption, clients and staff accessing or working at an SCS could be at risk of criminal prosecution. It's the federal government that is responsible for such exemption. In 2015, the previous government in place at the time had created a specific exemption regime for supervised consumption sites that made it very difficult to apply for an exemption. It was definitely an effort to prevent new sites from opening. This specific regime still exists today under Section 56(1) of the drug law, CDSA, and it requires every site to get a specific exemption from the Federal Ministry of Health in order to operate without risk of prosecution, as mentioned before. There's been a change in law with the new government that was elected at the end of 2015. So the change in the law happened in 2017, and we've seen a notable improvement in Health Canada treatment of exemption application and their communication and their openness. But this exemption process and the fact that people have to go through this each time they want to open a site has been identified as an important barrier to the rapid implementation of SCS in Canada, and this especially in the context of a public health emergency. And it's important to remember, and this was mentioned before as well, that funding is usually provided by the province, and so this means concretely that service providers have to navigate all these different levels of government, from federal government to get an exemption, to provincial government to get funding, and those governments do not necessarily share the same approach to SCS, and it makes things really difficult for service providers who are already, have a really high burden to just be able to provide the services and deal with the situation. So that's the legal and policy landscape we are working with and trying to improve. If you could change slides, please. The teleconference coordinated by the Dr. Peter Center is very important tool for us to do this work. We've been participating to the teleconference from the beginning, and we are grateful to be invited to the teleconference, even if we are not service provider, because this is for us an extremely important source of information about what is happening in Canada, how policy translate in practice, how they actually impact people, services providers, what are the barriers that people experience, what may be also the facilitators, and who are the actors across the country, what are the needs, how can we support them from an advocacy point of view, and also it's been really interesting to learn about implementation of new services and diversification of services offered at SCS and some of the challenges around that. So thank you to everyone who's been sharing those experiences. It has notably helped us inform our report that we released in February 2019, entitled Overdue for Change, Scaling Up SCS in Canada. That was a research project that actually looked at, what are the legal and policy barriers and facilitators to implement SCS in Canada. And because the situation is constantly evolving, it was actually a report that was meant also to just capture this evolution. And I hope that we can find a way to do it again, because there is so much that has changed since we finished our research, and all the information that's been shared on the teleconference would be precious to collect again and to share. So again, what the teleconference has confirmed in terms of what we had also observed in our research is that navigating different regulatory systems at both federal and provincial barrier, it makes the work really difficult. It has also confirmed that there is a clear need for a wide diversity of services, from low threshold services to comprehensive health services. That there are some legal and policy barriers to the implementation of new services or the way they are implemented. So I'm thinking, for example, of drug splitting not being allowed, or assisted injection limited to peers. And again, and I think that's this conversation today just reaffirmed that something that we found when we did our research, it was that one of the facilitators of implementation of SCS has been knowledge exchange and partnership between sites. And I think Jason just talked to that about how sharing protocols and experience have been so helpful in overcoming some of the barriers and actually being able to open new sites. And beyond our experience in Canada, I also just wanted to highlight that this conference is also an opportunity to share experience and the expertise that we have here in Canada beyond Canadian border, and to connect researchers and service providers from other countries to colleagues in Canada. So this expertise and this experience, which is really unique. I mean, it's quite amazing when you see the number of sites that exist in Canada compared to other countries in the world. I'm presently in Paris, and there is just one site, and there is only 2 sites in the entire France. So I think having this group and being able to refer people from other countries to this group for feedback referral has been really interesting, and maybe that's something that we want to pursue more. Next slide. As mentioned, also bringing people together offer opportunity to exchange on challenges and then mobilize around those challenges. And I just wanted to take a recent example of a letter that was sent to the Ministry of Health by several organizations before the election, asking for a measure to secure supervised consumption services at a critical political time. Given how sensitive supervised consumption services are to the political context, participants to the teleconference were nervous about the federal election and what it could mean, a change in government could mean for the implementation of new services, but also for existing services. In particular, people were concerned about those services who only have a 1-year exemption or had exemption that are expiring early 2020. What would happen to those sites? Would they get their exemption renewed? And so we discussed, aside from the conference, what could we do? And there were suggestions about asking the government to take a very simple, easy measure that would be to change exemption from a short-term exemption to a 5-year at least exemption, just to avoid any new application process in the coming years, to really make sure that all the work that's been achieved would be secure. 19 organizations sent the letter to the federal government, and we followed up with a call with the Ministry of Health staff, which was coordinated by Patrick. Thank you, Patrick. Unfortunately, we're told nothing would move until the election. Not super surprising, but I think it was very important that we mobilized and expressed our concern to also, set the stage for next step. So next slides, please. Now that the election have passed, I think we need to continue to push for legal and policy changes that will further facilitate the scale-up of a diversity of SCS in Canada. We've made, again, tremendous progresses in the recent years to normalize these sites, and I think it's indisputable that they are essential part of the response to the overdose crisis. But it would be naive to take all these progresses for granted, and more work needs to be done, I believe, to secure access to SCS in Canada. And so I think that's why community mobilization needs to be a component of this conference, and we need to find a way to have some aside discussion around advocacy with the participants of the conference. And just to finish, at the national level, the priority that has been really identified that we need to normalize, expand, secure SCS by getting away from the need to obtain a specific exemption each time we want to open or maintain a site. So what's been suggested that we could do that through decriminalization of activities related to personal use, and this is something that is coming back very often. Decriminalization would effectively end this exceptional legal regime. It would allow SCS to operate as any other harm reduction service. But if that does not happen now, in the meantime, the federal government could issue a class exemption that would automatically protect SCS that meets some minimum requirement from prosecution. So such class exemption would remove, all the administrative burden that is required and associated with asking for an exemption. And I think it would be a great manner for the federal government to show leadership, and hopefully that can influence provincial authorities as well by sending a clear message that SCS are valuable health services, needed, legitimate, legal. So thank you, everyone, and I look forward to continuing working with you and learning from you through those teleconferences.
Thanks very much, Cecile. Okay, so we have some time for questions now. So I'll open it up to the floor. So if you have questions related to lessons learned or just sort of questions related to SCSs or OPSs based on the collective knowledge here, I think that there's a lot of people with a lot of amazing experience, so who are happy to take questions. I'll start off with the ones that have come in so far. So quickly, the recorded presentation will be made available afterwards. And then a question that I think probably is on several people's minds, I would guess, is how do we sign up to join these teleconferences? How do we participate? So I'll turn it over to Patrick, I suppose, for that.
The key themes document has my email address in it, so getting in touch, I think. There's one point I mentioned during the presentation around certainly trying to keep it as really like the large majority as service providers, and so we're always trying to guard that jealously, just to make sure that it's that it kind of stays that, because otherwise, if too much dilution, then it just changes. It becomes a different call. And I think this was so wonderful for me to have this hearing things that could be improved, because it's just giving me it's just perfect time to hear that. And I think again trying to make smaller groups, but please get in touch, and we can go from there. Yeah.
Okay, thank you. So a question came in and it asks, any data collection on SCSs, OPSs, and the decrease of criminal activity? Is anyone aware of anything related to that?
This is Jason. So we know our police have gathered up information from Calgary, Edmonton, Vancouver, and Lethbridge police services around crime rates before and after opening. The one reason benefit for us working with police is they actually gave us a baseline for the last 2 years in the area around before we opened. And so that actually is going to allow us to combat any perceived issues in the community. And they've helped us strategize on ways that we can address any issues that could come up in a collaborative way. So it's not just weight on us, but it's all both of us going together. So, but I don't know if the Saskatoon Police Service has permission to share that those reports out, but I know that police usually collect that. And this question does come up often, but I'd just like to point out that we have to be very careful about this. This is a health issue, and we need to make sure that we're addressing health issues, not justice issues. If they want justice issues dealt with, then they need to deal with that separately. But we're all running on a shoestring budget, and if they expect us to respond to justice-related issues that are dealt with in systematic policies that have nothing to do with us, and a lot of times these are deep-seated issues within the communities before the OPSs open up, which is why the need is there. And if they expect us to be able to address criminal issues on health dollars, that's setting a dangerous precedent when we're already overstrapped in terms of health spending.
Thanks, Jason. Lorraine, it looks like you're trying. I'm just going to unmute you. Go ahead.
I just want to add to what Jason's saying as well is, depending on where your SS or OPS is located, for us, we have two that we operate and they're both downtown. And so we do sit on the police community liaison committee, our local police, and they sit on our SCS community liaison committee, and that's an opportunity to share information. And sometimes there are signs that may seem like there is an increase in certain type of petty crimes, but it's important to, sometimes people want to say, oh, that must be because the SCS or OPS opened up, when in fact there's other factors, like there are 30,000 more people living in the community than there were 10 years ago. There's an increase in poverty. There's a lot of other services in the neighborhood. So I just want to echo what Jason's saying, is that stats can be very misleading, and they can really be used to an opposition of a health service. And so they just have to be kind of looked at carefully and questioned.
Thanks, Lorraine. Okay, a question for Patrick. Somebody, the picture that you showed of the site at the Dr. Peter Center, they're just curious about what the shower is used for.
Oh, it's a foot bath, and we have service users that might inject in their feet, and it's for cleaning feet, and folks seem to find that helpful. There was a little bit of an inadvertent. We shared that as something that was a helpful thing, and I think, as Lorraine noted, it kind of had an inadvertent effect of. Then in Ontario, I think somehow it almost became a required or something.
It actually did. So when the Ford government won the election, the provincial election, they kind of put a hold on the funding and made everyone who was receiving funding, or anyone who wanted to open up an SS, those who were OPSs, had to reapply for funding under the Consumption Treatment and Services funding stream, which was something that they created. And it had a lot of mandatory design elements, and one of them was a foot bath, something that we got when we saw Dr. Peter Center. Thought, isn't this a nice luxury to have? And now it's become a mandatory design feature.
And no, I mean, the cost, I don't know engineering and all that well, or plumbing, but I mean, just the cost to have that plumbing can be quite significant, and it's not necessary in any way, so yeah.
Okay, thank you. So there are a couple related questions. One person's asking if there is, to any of your knowledge, is there any sort of repository that exists for information on SCSs currently? It sounds like maybe not, but I'll put that question to the group. And then related to that, what are some of the knowledge exchange and capacity building needs that you feel are needed by service providers who are supporting people who work with people who use drugs? Maybe starting with the repository. Is there anything that exists currently, or?
I think CATIE is probably the closest. I don't know if you guys have a repository of policies and procedures, but that might be the closest. We're very interested in building one and creating it, but I don't think anything exists right now. So
okay,
definitely something to do. I was going to, for the next question, at the risk of putting Sean on the spot, the AIDS Bereavement Office of Ontario, I think, did some important work around in that area around supporting staff. Maybe I could hand it over to Sean to just talk a little bit about their work.
Thanks, Patrick. Yeah, so the AIDS Bereavement Project here in Ontario was created in response to the situation with multiple deaths and loss in Ontario quite some time ago. And the focus for those staff had been altered so that programs like supervised injection services could access that support around multiple loss and grief a couple of years ago. So some of us were able to access that support. And here at the Works, we did have that project come in quite frequently both in a group setting, and they were offering individual sessions for staff who maybe just didn't feel that a group session was something that they could benefit from. So the staff at the AIDS Bereavement Project opened that up a bit and did these kind of one-on-one sessions. They actually, our model here at the Works involves a lot of people with lived experience who work in our chill out and also on outreach outside our doors, our program. And so we felt quite strongly that they would also benefit from the support of the AIDS Bereavement Project. People have some additional issues that they need to grapple with, and very specific, and then some of the very similar things that staff are going through. So they opened up some sessions for our people with lived experience too. And I can't say enough about that project. We have lost the capacity now to bring them in, so we're struggling to find something else. But you know, it's a really important part of what management can do to assist. You know, we have EAP, we have other supports. Having a low staff to supervisor ratio is important, so people have access and can debrief together. But having someone come in like that, it's been great. So yeah, very important.
And I just want to add, there's a lot of challenges around that, you know, meeting the support needs of staff, especially if you're a small team. You know, at our Queen West site, it's a staff of 6 full-time workers, and at Parkdale, it's a staff of 4, though it'll be 6 soon. And it's shift work, so it's very hard to create opportunities for people to come together, for people to access external sessions. So there is an organization that does offer some support groups for frontline workers, but sometimes they're at a time when we would need to shut down the service for anyone to be able to go to it. So I think there's a need for both sites and the cities in which they exist in to look at creative ways to create these opportunities, given that all the sites in Toronto, for instance, have different operational hours, different shifts, different kind of staffing models. And so it's the challenge that I think many of us are facing now is how do we build in a variety of supports, because we too have an EAP program and people get one-on-one supervision with me, and we have brought in the Ontario AIDS Bereavement and Resiliency Program after we had a couple of deaths. But it's a challenge. So we're looking at bringing someone in on a regular basis that is kind of separate to the support they might get from their manager. And I would say about teleconferences, I just want to add that's another challenge. Often at the teleconferences, it's managers and supervisors who are participating. And again, it's another opportunity for the teleconferences to have some sessions that are really for frontline workers.
This is Jason here. So like one of the things that we try to do is offer, we had a pretty crappy pension plan and nobody was signing up for it. And so what we ended up doing was shifting it to a wellness fund. So now staff have the ability to have, you know, portions of their gym membership paid, or whatever they view is going to help them benefit them in a kind of a wellness way. And then we also we just signed an agreement yesterday to bring in an elder once a week, or once a month, sorry, we can't afford them once a week, I wish, but once a month, where they're going to be able to provide support to staff, and then another time a month to provide support to clientele. And then we also have a pipe carrier on staff, so they can do pipe ceremonies and types of, there's different ceremonies that we can connect people to, whether it's sweats or night lodges or whatever it could be that they need to do for healing, as we try to follow the medicine wheel teachings.
Okay, thanks everyone. Another question. Someone's asking about the type of engagement that you've learned through the teleconferences that seems to be the most successful when trying to engage surrounding communities near an SCS. And related to that, someone's also asked a question about engaging provincial governments around the importance of an SCS in a community. So sort of engagements at the community level as well as the provincial level, sort of what's come out of the teleconferences related to that.
Maybe I can just say from our experience here and on teleconferences and in individual conversations with people across Canada that there's no one thing that works on its own. That I think you have to try to do a whole range of engagement opportunities. I think the one-on-one kind of relationships that you build, being available to people, you know, the local Tim Hortons. As I said before, Ryerson University is very close to us here, so checking in as regularly as you can. Is there anything we can do? You know, can we work together on a project that would impact the outside in a positive way because it's all of our neighborhood? How can we all work together? You know, we've done presentations there. So sharing data, doing the tours, I think has universally for programs like ours, having a tour, there's a lot of misconceptions about what happens at a supervised injection service, what it looks like inside, how you staff it, all of those details. So we have done a lot of tours with our local police, with the local BIA, and the BIA has helped to coordinate those tours. So we've worked together on offering those. We sit on BIA committees. You know, it can be very intense, and like Lorraine was saying, some programs don't have a lot of resources, so the meetings that you're at may take away from some of the things that you could do at the service. But I think, you know, we've all kind of come to the conclusion that there's an array of things that you do and that you can do that can work. You just have to keep doing them.
I would agree with the multifaceted approach, and that relational approach is really key. And from when we were looking at it, we really kept it to one person that people could go to at the agency, so that people at least had a face to do it. And you can get confused when you have multiple options on where you can go. And so having one person kind of be the spokesman for the entire consultation is really key. That's not to say that they're doing all the work. Of course, there's a team behind them, but you need to have that one person so that, especially when you're looking at trying to get wider public buy-in, they have to be able to feel like they can trust that person, or at least know that they're authentic in what they're saying. And so you need to have one spokesperson, and it should be the head of the org, because people will always have the question of who's responsible for this, and you have to be able to shut down that conversation pretty quick and say, I am. And then otherwise it's going to become a gripe session where they're going to try to go around that person and go to like to the board chair or whatever it is. And you have to make sure that it's really clear on who's speaking on behalf of the org and who's responding on these issues, because the naysayers will they'll try to weasel in any way they can and try to dominate that conversation. And you have to have a strategy in place to shut it down. And it's a lot easier when it's one person who knows all the parts, versus having multiple people that they can go to, because they can then do the good cop, bad cop thing. All those types of problems can start.
I would say in Toronto, you know, prior to opening up, we actually, the three original sites, South Rideau Community Health Centre, the Public Health, the Works, and our agency, we actually hired a company to help lead our community consultations. We actually worked with the city as well and our local councillors, and it was quite strategic. And so there was focus groups, there was online surveys, there were town hall meetings, there were open houses and tours. There was a variety of means that we used to engage our community. Then after that, each site was kind of responsible for the ongoing community engagement, because it looks very different, you know, at Parkdale Queen West Community Health Centre than it does at the Works. But we do meet regularly still, all the sites in Toronto, to kind of share issues that are being raised by our community and different strategies that we're using to address them.
I think it was important through the consultation too. The question that we asked the community to respond to was, what are your concerns and how can they be mitigated? So working with the community to identify those and realistic solutions, I think is really important. It's not a yes or no kind of discussion that you're having. It exists or it doesn't exist. It's more about what is the impact for you? What can we do to work together to ensure that the experience for you or your constituents or you know, your patrons at your restaurant are feeling like their issues are being addressed. The other part that I didn't really talk about is the outreach, and those outreach workers that we have here, getting out on the street every day, being easily identifiable by the neighborhood that they are outreach workers from here. And we've had a lot of positive feedback from people in the neighborhood, residents and other people who go up to the outreach teams and say, oh, thank you so much for the work that you're doing. It's really important, and tying that back to the site. So I think that's been a really important strategy that we have been lucky enough to get additional funding. But, you know, programs need to have enough funding for staff around the issues of the work and how difficult the work is, and if they need to go off the floor to try to figure out how they're feeling or walk away for a minute because of a particular situation, and then having enough staff to go out and do outreach. Programs are not funded for that; they can't do it, and then they're at you know, more of a risk of community concerns to start to become overwhelming because they have no neighborhood exposure. So I think the funding is really important.
I would also say, like, a lot of times people who detract from the sites or go against the sites, they tend to speak for, I've spoken to my people, or I've spoken to a lot of people. And so whatever engagement strategy you have to be able to cut them off. It's like boxing somebody in a ring. Like, you have to cut off all the angles. So we knew that there was a couple orgs that were going to say they spoke to people in the community. They tend to think they speak for a lot more people than we know they actually do. So we went and spoke to literally every resident in the community. We went to every house in the neighborhood, and that prevented that immediately shut down discussion, because we knew at the end of the day that's all they had was make believe, where they were saying they'd spoken to hundreds of people, and we knew that it was more of a political thing. And so you're going to have to put in some legwork, and you're probably not going to be funded for 99.9% of that legwork that you do in the consultation process.
I just want to add, we also had some very specific strategies we use to engage people who use drugs, both in terms of developing the service model and design during our community consultation. But after we opened up the service, we utilized our other harm reduction services like outreach workers and so on. But we also recruited people that we call SCS ambassadors, people who were using the service and who had good large social networks, and had them kind of go out and promote the service and answer questions and give us information. And we also have people who sit on our community liaison committee who represent communities as well. And it's important to think about that, because we often think about the people who might be in opposition of our services and needing our attention, but it's really also the people who are using our services, or who we'd like to use the service, who aren't engaged yet.
Okay, thank you all for that. We're at 1:30 now, so unfortunately we are out of time for questions. I just want to say thank you so much to all of our panelists and speakers for sharing their experiences with the teleconference and just their knowledge related to this topic overall. And thanks to everyone for joining us today. As I said before, this webinar will be made available on the CATIE website, and you'll also receive an evaluation form to complete following the webinar. So thanks again, everyone, and have a wonderful day.
Thank you.
Thank you.
Thank you.